Okay, everybody, it's Dr. Hyman, and so we're going to forge ahead now. May have to stop a few times to let a few people that are coming in a little bit late to join us, which sometimes does happen. And this one is talking about the coronavirus. It's going to be some of the materials you've seen before, but also an emphasis on the questions I'm getting most commonly, which is travel, schools, and that's something that we'll try to cover for you. Let's jump into that. Everybody should be able to hear me. This has some of the introductions of the people I work with, the people I write some of the guidelines with. Those are some of my boys, which is why we all work so hard for our kids. These are some of the books for the AMA, just in case there's one of my physician patients on the line and they can say that I gave a talk and I didn't give the proper admonitions that are required for a continuing education thing. So there it is. It's all on there. What these books are the ones that I've written for the AMA that a lot of you know about, and things that people find helpful as references. They're admittedly written more for the general physician groups, not for the public, but nonetheless, so I've exposed it, said it, done it. Very appropriate for our discussion though today is some of the different guidelines. So our coronavirus guideline, the national guideline, we are actually starting to work on a new revision. That will be updated. Also, some of the articles that I've written that have been published in some of the different references about how to evaluate patients with coronavirus, they've been republished in some other journals. So people that want to look online for the actual journal information, that's certainly available to them. What we're going to do is we're going to go forward and go after a couple areas: epidemiology, and then testing, and then we'll talk a little bit about travel, a little bit about masks, and a little bit about schools, because those are all the areas that kind of overlap with each other to try to help you. Get your pen and pencil ready for this, because when I do give some of the dates or some of the time frames, I think it's very helpful for people because they have a better idea of how to think through what is the right answer for their travel question or what to do with their family. Okay, here we go. Epidemiology. Okay, so remember, this infection is primarily spread by respiratory droplets. That's from coughing, sneezing. You can even get some respiratory droplets from talking, right? Now, a droplet is defined as a certain size, which means that it is usually fairly wet and heavy, which means it usually travels about 2 to 3 feet. It does not usually travel 6 feet. Everybody says, well, how come they got 6 feet different? Okay, so in the WHO, in certain countries, the recommended distance is about 1 meter, about 3 feet, right? So people say, well, I've heard it can go farther. We're going to talk about that, but let's just talk about the regular mechanisms of transmission, which is the heavy droplet. It goes about 2 to 3 feet. Dry air, if somebody says, well, I live in a dry environment, could it go further distance? Yes. But when you have dry air, you have less ability, less variability in how long it lasts. What happens is that the virus, if it's in a dry environment, tends to kill itself off quicker. It doesn't stay as viable because it has to be in moisture. It has to be inside a cell, okay? So droplets are defined by a certain size. So you see this here, greater than 100 microns, also called ballistic. Some will call this inhaled aerosols. And by the way, people always say, well, I've heard about these wet, moist environments for kids and stuff. It's not in breast milk, so don't worry about it, right? And there is a big discussion you've heard about aerosols, right? So an aerosol is by definition a smaller droplet. So look here. Look at these numbers, right? So you inhale, that's the big droplet, the big one, the fast one that drops, right? Then there's these ones called thoracic, but the respirables, the little tiny ones, these are what we call aerosol, or some people call them droplet nuclei. They get diffused quickly. Now look, it's very important. There are descriptions in the literature of aerosol. There's a description for a choir. There's a description for a Chinese restaurant where it seems to be the transmission was an aerosol. And aerosols do last in rooms for a few hours. But the most common reason you'll see that is from medical procedures, not generally from people in a room, unless, of course, everybody takes their mask off, there's poor ventilation, it's a small room, there's lots of people. So there's even these guidelines by engineering controls where it says if the ventilation is less than 3 liters per second per person, which is a very low rate, meaning somebody hasn't turned it on, and you've got a lot of people staying next to each other, probably singing or shouting or screaming together, then yes, you could get an aerosol transmission. But that is much less common than the regular droplets, and you have to have all these scenarios working together. Small room, no ventilation, no masking, where you can start to get some of this aerosolization, right? So does it happen? Yes. Is it the major route? No, right? Are there people that are always advocating one way or the other? You bet, right? But overall, this is a smaller chance, right? So those are the kind of things where people say, well, if I'm going to be outdoors walking by a beach, do I need a mask? No, right? If you said to me, you're going to go into a store, right? Or you're going to be in a crowded thoroughfare with lots of people shoulder to shoulder, okay, that's a different story, right? And if you start saying, I'm going to be in a closed room, right, then those risks start to go up a little bit more, right? And there can actually be toilet aerosols. There's actually been described in some of the literature from China. Now, what this was tall buildings that have these huge tall stacks of apartment buildings, and they actually saw aerosolization because the way the water was going through the systems after flushing, there would be some aerosolization on another toilet in another location. Pretty worrisome, right, for most people. Doesn't seem to happen commonly, certainly in the States. Would have to be in very tall buildings that don't have certain building standards that we have here in the States. But nonetheless, so could there be aerosolization? Yes. But is it a common mechanism, especially in the United States? No. So it's not something that you have to worry about very much. Furthermore, let me give you some other information, right? Measles, that's for sure an aerosol infection, has a household attack rate of 85 to 90%, while corona is maybe at most 10 to 40%, right? So tuberculosis, cocci, some of these other ones, they do aerosols. But we don't see much aerosolization from this type of infection in households or even in healthcare workers. Because if we do some masking, it's enough. And remember, there used to be this whole stuff about, measles parties or chickenpox parties, right? This is where you got high levels of aerosolization. That's when you know that your aerosolization is going to be a little bit less, right? Okay. Now, there's no transmission if the infected person was sick for at least 6 days, maximum 10 days. It's rare if it's a severe for 14 days. Now, I want you to remember these numbers. Very important, very important. If you have somebody that's sick for at least 6 days, at maximum 10 days, and you'd have to have somebody that was hospitalized and severely ill to get up to 14 days, they could still transmit. So remember those numbers. When you start thinking about, okay, I know somebody that got the infection, somebody was sick, somebody had a problem, what does that mean? How many people does that impact, right? Those are the kind of numbers you have to think about, okay? And again, generally by day 8, you're done. Meaning that if somebody had the infection and they had a relatively mild infection, maybe a moderate infection, but certainly they weren't severe, they weren't hospitalized, then they are no longer transmitting virus by 6 days, maybe 8 days, maybe if you want to push it 10 days if they're really sick, but you got to get much worse if you're talking about somebody that's going to be getting out the virus after so much period of time, right? So please keep that number in mind, very helpful, okay? Next. Now look, this talks about, again, the particle size, but look at this little chart here, right? So keep this in mind. If it's the big, heavy viral particle, it goes to the floor within 3 seconds. If it's a medium-sized one, okay, it lasts 2 minutes. When we talk about those tiny aerosols, could they be suspended indefinitely? Yes, it could go up in the air, right? But if you have it out in the air, outside, where it's going to aerosolize, right? First of all, a lot of studies show that the virus is gone within 6 minutes of sun exposure. Sun exposure kills this stuff off very fast, right? And many studies show that even if you get an aerosol, remember I've already told you, if it's not in a cell, if it's not in water, it starts to break down very quickly, right? And when they do these studies and say, oh, look, I got some virus, you can get viral particles, but not necessarily a live virus with an aerosol, right? There were some that said, okay, look, we were able to retrieve a viable virus at 16 hours. And one said we got it at 8 minutes, but you can get a starting feel like it's very rare for this stuff to ever do that. And what's more, no study has ever been able to culture the virus from the air. Now, this is true for measles and TB. I'm not saying it doesn't happen as an aerosol. I'm saying it's droplet, 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 the large, heavy stuff. That's what you have to keep in mind, right? Now, there are ways that this is studied. So this is the original aerosol chamber. This came from Fort Detrick from 1966, where they actually were testing people, right? And there were actually pictures taken, right? Where they could look at, from 1942, this is the Genesis experiment from a long time ago, where they looked at droplets when people cough or sneeze and how it disperses, right? Now, this is a picture you may have seen where they talk about saying, well, wait, we saw that you could have this image taken of somebody rearing back, really expelling all kinds of stuff, and it can go out for meters. Okay, that's true. Anything is possible, right? But first of all, I've already told you that the heavy, wet droplets, the one with the live virus, they drop out quickly. 2, that aerosols that start to break up, you can't culture virus very easily or readily. 3, if it's a dry environment, it dies out very quickly, right? So is anything possible? Look, anything is possible, but in general, this is extremely unlikely mechanism of transmission when you start going out this distance. That's why, by the way, that we say, look, if you give 2-3 feet, WHO standards or the American Academy of Pediatric standards of 3 feet, you're probably fine, right? Because it's very unlikely that you're going to have troubles if it's any different than that. Okay, now look, some other important numbers. Get ready for these numbers. Very important numbers, right? The incubation period is usually about 5 to 6 days. Okay, what does that mean? That means that if you're exposed, on average, takes 5 to 6 days for the infection to show up in you, right? So when people start saying, well, what if I travel and get on a plane, or when do I get to the plane? Okay, so you have to start keeping this in mind. People say, as soon as I get to my destination, I'm going to go get tested. Well, that's great, but if you pick something up while you're traveling, it's not going to show anything. It's a waste of your time. If you want and you have time, if you really want to capture this, then look at this number here. Look, look, look. 97.5% of people, right? You see that number? That number means that if you wait for about a week or so, and then you test somebody, you have about a 97.5% chance that this is going to tell you one way or the other, right? So now when people travel and they say to me, well, I want to go visit my family, one of the questions you have to consider is, okay, how long are you going to be visiting with your family? Because somebody says, well, I'm going for a month. I'm going back home for a month. Okay, now we have a little bit more latitude where I can say to somebody, okay, look, then maybe don't see them for a week. Or if you're going to see them, maybe do it at a distance, right? And, maybe outside, something like that. And then after you've been there for about a week, okay, then go and get tested. Now you're going to have a pretty high likelihood you're going to know what you're dealing with, right? The viral shedding. So that usually can start around 3 days after exposure, right? But you definitely have it 24 to 48 hours before any symptoms, right? So this is an important number to keep in mind when you're traveling. We're talking about schools, because you will say, well, that person got sick on this day, but what you have to know is they were shedding virus 24 to 48 hours before. So when people are saying, well, should I get tested, or when should I get tested, right? That's something to keep in mind. about those time frames, right? Now, mild cases can shed virus for 7 to 12 days. Now, we just talked earlier about, we think 6 days, maybe 8 days. You want to push me on severe, right? And severe cases, maybe 20 days. But remember, we talked about transmission stops around 6 days after symptoms, which means, could you get a test and could it show virus? Yes. Are those viruses transmitting? Meaning, you have enough of them? Are you coughing or sneezing enough? Are you exhaling them enough that would actually reach out and transmit to somebody else? That becomes very unlikely, right? So the viral shedding is usually no more than 3 days after last symptoms. But again, there's been some studies that show this virus that if you go and test people, hey, I can fight it for 6 or 8 weeks. Look, anything is possible, but it's not necessarily so that what you're getting is any live virus. It's particles, it's leftover stuff, but it's not something that's necessarily going to be transmitted, okay? The majority of people will have no or mild symptoms, right? Pregnant women have virtually no symptoms, right? And the virus also can be shed but not be infectious. And in particular, this comes out with something called PCR. Now, this gets a little technical, but I want you to stay with me on it. It's very important, okay? They will say the gold standard, which is true, is PCR testing, right? And that PCR testing gets you a result, positive or negative. But what it doesn't tell you, unless you ask the lab, is something called the threshold cycle count. So what you could imagine is the following. This machine keeps testing the sample and testing the sample and testing the sample in different cycles. And you could imagine that if there's a lot of live virus, you do a few of those tests and boy, you've picked it up. But you could also imagine that if you've got this leftover, a few dead particles, a few little pieces, and you got to keep testing and testing and testing and testing until you find a little bit, that would be a high cycle count. And if you get to a high cycle count, the test is positive, but it's not infectious, right? And so that is very important. Also, it's important to know that even though you could see differences in how long the viruses last out of people, there's not a big significant difference between the viral loads of an asymptomatic person or those who are severe. You'd think that the severe person would shed a lot more. Well, the severe person may shed a little bit more, may shed a little bit longer, but in general, not a big difference, right? Okay, here's another way to look at this, right? So look. Here's how somebody's feeling. They don't feel anything, they're incubating, they have their symptoms, and they have resolution. Here's what's going on with transmission, right? So you got this period of time where you're not transmitting, but you could be building up a little bit of virus, and then before their symptoms, because here's your symptoms, right? You start having an infectious period where you start having the virus go up, right? So we talked about those usually 24, 40 hours, something like that, where the virus is now shedding, you're infectious, you're spreading and stuff, and it overlaps. And then after the symptoms go, right? Then you usually say, okay, we have resolution. Like we usually say, okay, usually by about 3 days afterwards, you're done, right? So when you have that scenario, when you're about 3 days afterwards, that's when it goes away. So that's one way to kind of look at this visually, okay? Now, what comes with that is the following, and that is surfaces, right? So people talk about when they're traveling in school, they're always talking about the surfaces. Overall, these viruses do not do very well on surfaces, right? One study had that the half-life of a virus was 1.5 to 2.5 days. Now, they said that they saw some virus lasting for 20 days when you get to 20 degrees Celsius, but in that study, they're going to tell you about these. They're going to say, oh, we heard it was on a cruise ship for days and days. Okay, look, if you have a virus with no light exposure, right? Because remember, I told you, UV light outdoors kills this thing, right? So that's why I'm always saying to all of you, get outside, exercise, right? This is so critically important right now because the UV light will help kill this off, and you'll have the opportunity to take care of yourself at the same time. It helps with circadian rhythm, and helps with depression, and helps with everything. Get outside, right? So could this stuff last, right? So yes, there's some data for that. So let's take a look, right? Aerosols And this looks at how many hours after an exposure there's viable aerosols, right? You can start seeing this dropping off very quickly. Here's copper, cardboard, stainless steel, plastic. This is SARS-CoV-1 and CoV-2, the two different SARS viruses. You can see how quickly these things drop off. That's why when you're traveling, it's very unlikely that you're going to have any trouble with surfaces. Why? Because you have to envision a scenario where somebody has no mask on, somebody's highly infectious 24 to 48 hours before symptoms, or they're having symptoms and they're traveling, which is, again, highly unlikely with all the, people trying to be careful and stuff, but nonetheless, like you have to give it to you, okay? So totally infectious, no symptoms, doesn't care about the world, doesn't do any distancing, masking, anything like that, coughs and hacks right onto a surface with a lot of wet droplets, and then you come by within the next few hours and you swipe all that up with your hand and then you rub it all over your eyes and your nose and your face, right? Well, okay, anything's possible, right? But I'm talking about medical reality. This is generally not going to happen, right? And so that's why surfaces in the traveling world is probably not a big deal at all, right? Okay, next, contagiousness, okay? So this is the concept called R naught, right? Which is the reproductive rate of epidemic. And generally the number that's being used for corona is 2.5, right? And there's some people with different numbers. Now, let me just give you an idea. The R naught for measles is 10, right? Means that for every person, if you don't do any mitigation and you have an average person, they infect 2-3 people. But hold on. When we talk about averages, you have to be talking about what makes average. So average means that everybody is equally likely to be a source or to obtain an infection. But that's not true, because some people are younger, some people are older, some people are doing different things, some people have different immune systems, right? So that number of 2.5 for the epidemic is probably an overkill depending on the population you're looking at. By the way, by comparison, flu, the influenza, the rate is 1.3, right? But when you do mitigation, when you start doing social distancing, masking, those kind of things, your R naught, your contagiousness starts to drop. And that will end the spread, right? So there's something called HIT, which is the herd immunity threshold. There's a number for that, right? And so the larger your R naught, the more of the population has to be infected to achieve immunity, right? So what that means is that if you have a population of people and you have an infection that quickly jumps in easily between people, well, you're going to have a lot of the population immune. But if it doesn't jump quickly and easily, if it's a 1 or a 2, then maybe you don't need that as much. So the traditional calculation for the hit rate for coronavirus is probably around 70%. But there are studies that say, well, wait, but that's not the average person. That's not that everybody's equally available. So you can imagine, let's say somebody gets sick. They go home. They're not out meeting people. They're not out infecting people. They live alone, or they have family members that distance from them. So all of a sudden, they're not infecting the average 2.5 people. So you could see where there could actually be some herd immunity as low as 15%, right? Now, there is a discussion lately about, well, if we give the vaccine, we could get some herd immunity, or we can just let the infection go around, and if the infection goes around, you'll get herd immunity. Now, look, the traditional herd immunity was always based on vaccines, not by letting everybody get sick. But on the other hand, right, with how many people actually do well with this infection, an argument could be made that, well, if you have a lot of people got sick at once, or that it was not percolating along with all the different mitigation efforts, an argument could be made that there would be a less chance of a problem if a lot of people got it at once, right? So it just depends on the population you're talking about, right? Now, problems with predictions, okay? So the original predictions were based on issues with things having to do with the Imperial College of London, okay? Now, this is based on Ferguson's work, where they said, okay, we say that this is going to be 2.5 people on average, and therefore you're going to have to get 60, 70% of the population to have herd immunity if you ever want to stop this. The problem is those people have been wrong before. So the people told about mad cow disease never happened, right? And that's because individuals vary in their susceptibility. Also, don't forget, some of that data was based on things that had to do with other factors, in particular the nursing home issues. The nursing home issues were something that skewed the data significantly. So when you're traveling, right, you have to start thinking about this. Where am I going? What's the risk groups, right? Am I going to go visit my elderly parents, right? That's where you start having to do some calculations and thinking about what's the risk, right? If you want to look at any of these models or forecasts, then I recommend the Rice Lab if you want to get into that kind of stuff, okay? All right, so that's a discussion about the epidemiology. Quick rest stop. And now what I want to talk about is the testing. After the testing, we'll get to those other things about the travel, right? So the testing, obviously, is what people are always asking about when they're traveling. We talked about some of the times and the numbers before. That's why I asked you to write them down because it'd be helpful for you. So when we talk about testing, we talk about the nasopharyngeal swab test, right? And that's looking for the antigen. That's live virus. Now, there's different types of tests for this, right? So the gold standard, the PCR, we talked about that a little bit. We talked about that threshold cycle count, right? There's other ones, the LAMP, the NAT, the FIA. Now, by the way, I even wrote down some of the companies that do this. Now, keep in mind, when people say, well, I went and got the 10 or 15-minute quick test, what you're getting is one of the NAT tests. There's nothing wrong with that. It's a helpful test. It's a good test. But I have to be academically honest with you. It's 100 times less sensitive than the PCR. So is it possible that you could get one of those rapid tests and it would be falsely negative? That is possible, right? In general, it's a good test. It's a reliable test. I like it. I send people for it all the time. But you have to know, this is why you have to have a doctor that interprets the tests, because the interpretation depends tremendously on the history. What's the dates? What's the time frames involved? How do we consider that in the context of the person? Please keep in mind, folks, there has never been a perfect test in medicine. There will never be a perfect test in medicine. Every test is a trade-off. And that's why you have to keep that in mind of how to interpret this, okay? Next, you could do testing from the lower parts of the lungs. Nobody does that because it would be a pain in the butt to try to get that out of people, and you don't want to do that. There are approval of other tests. Those are less accurate. What is coming, right, is this big push of all these companies doing the quicker, simpler tests that are going to be ones you can do on your own. Ones that can be done quickly in a doctor's office, even more so than the current ones that we have, right? So remember, we talked about the virus, we talked about the shedding, we talked about those threshold cycle counts. Please keep that in mind, because once again, that testing makes a difference. Could you get a positive test result? Yes. Is it viable virus, right? It could be or could not be. Does it fit with the time frames of how long you're exposed, how long you're sick? That's the question that has to be resolved with each test, okay? So we talked about virus shedding, 24 to 48 hours before symptoms, peaks 1 day after symptom onset, usually gone 10 to 14 days. Remember, I gave you some different numbers, right? That about how long you can find that for, right? So finding the virus does not mean it's infectious. Remember, I've told you this, right? You're not able to culture a live virus usually after 7 to 8 days. CDC, again, we talked about this. Virus usually gone by 10 days. If you're hospitalized severe, 10 to 20 days, but you may not be transmitting it, right? So again, it has to be taken, it has to be tested in context. Now this gets a little busy. So this is something I really need you to understand in this concept of why you have to somebody that's interpreting this and going through this with you, right? Because this looks at the probabilities, right? And so what that means is the following. It means that if you're going along here, right, and you're seeing that the there's no virus, no virus, and all of a sudden you say, okay, I got a virus. So the chances are that when you're at that peak of symptoms, right, then the chances that you're getting a false negative result gets lower and lower and lower. But as time goes on, as you get further and further away from the infection, then if you start testing somebody, you're also more likely to get a false negative a change, which means, what this means is you might find virus, but it's not necessarily true virus. It's not viable virus. It's not virus that you're being transmitted. It very much depends on what the patient is being tested. Here's another way to look at it, okay? I know this gets busy, but please stay with me, please, please, please. This says, depending on how sick the person is, how probable you think their infection is, that influences the result. So what that means is that you could have a situation where as you're in somebody that you say, boy, they got a great history. They had a clear contact. Their symptoms seem to be classic, right? So their pre-test probability is very high, right? So if you give them a PCR test and it's negative, right, then that means that is more chance that you might be getting a false result. Whereas if somebody has low chance and you test them in negative, well, that makes sense. It's consistent with them. So all these tests require interpretation based on what the patient has, right? Okay, now, blood tests, right? We just did the PCR, the nasal smears, all that kinds. Let's talk about blood tests, right? So the blood test looks for the antibody, not the antigen, right? And this is directed against the virus. So there's two types of antibodies we talk about, the IgM and the IgG. So the IgM goes up after about 4 to 6 days, peaks around 12 days, declines after about 35 days. IgG goes up around 10 to 18 days, which is why people say to me, I'm going to travel, I'm going to get my antibody tested. What are you doing that for? It makes no difference, right? Because this takes days to weeks to even show up. So it's not going to tell you anything of any value, right? And that's not necessarily going to help you at all in your decisions about travel, about people coming to visit you, right? The important thing about this IgG, a lot of discussion you see in the papers and the literature is about what does it mean? So there's a lot of controversy in this area. I just want to go through a few pieces. First of all, the IgG, that's the long-acting one. We know from past SARS outbreak and MERS outbreak that the IgG can last for 2 to 3 years, right? And we've already seen in this period of time, we have people that got the infection early on and still have antibodies 9 months later, okay? Now, it is true that if somebody had a mild infection, then they might not have evidence of antibodies anymore. Or if they had evidence of antibodies, it's dropping off more quickly, right? So it is true that you do get antibodies. It is true that you could have less antibodies if it was a milder infection. It is true that you might lose some of the detectable antibodies after a period of time, especially in somebody who is mildly infected, right? That's true. But I'm going to show you some other things to keep in mind when you're talking about this, okay? So next, people talk about the pinprick blood test, the lateral flow assays, which are reasonable tests. But again, the one that's the best is the ELISA test for the antibodies. That's what I do. That's what I recommend. That's the regular blood draw, okay? Now, stay with me. Very important, okay? I know you said, oh, I can't believe I have to look at this, but this is very important concept because I have to do this, right? So stay with me. You have the antigen, which is the virus. Comes in, stimulates what's called a macrophage. The macrophage stimulates the T cells. The T cells stimulate itself and also stimulates B cells, okay? Now, why am I showing you this? Because it's a very important concept. Because immunity is not just antibodies. Antibodies is one part, but cells is another part. So you can have immunity and not have any antibodies. And this is what happens with every single virus we've ever seen, ever. All viruses cause an immune response. Some are antibodies, some are cellular, the cells, the T cell, B cells. Most of them are both by far. And could some drop off? Yes. But in this particular case, you're going to see that you're going to have the cell immunity anyways. So when people say, well, this guy had a test and it didn't show antibodies, okay, there's a whole bunch of questions there. You know, did he really have the infection in the first place? Which was the test? Was it an ELISA test or was it a pinprick test? When were they tested? Over what period of time? Were they a severe case? Were they a mild case? And you're not testing for the cellular immunity, which is also operating, right? I'm not saying that somebody can't get this infection again. It is possible. There are case reports of that. It's pretty rare. I mean, you're talking about, you know, over 20 million people in the world have had this, and you got a few handful of case reports. But in general, it's going to be from a different virus. It's not going to be the same virus. And in general, those viruses that are going to be the new ones that are similar are not going to be nearly as difficult to deal with, right? What we're not talking about today is a lot of the clinical features and past virology, which I've talked to all of you about before, because that highlights some of the differences in the viruses, and in particular, where 10 to 30% of the viruses don't have anything to do with anything serious except just the common cold. So look at this. Very important. Follow me. This is really important. Watch. Okay? This study of patients with mild disease. They carefully studied them and said, okay, 100% had T cell response, 100% had IgG antibody response. Okay? Good. Everybody clear. You had the COVID-19 infection. You definitely showed that you had antibodies. You definitely showed you had the immune response. Very clear. Okay? Then these same people took blood samples because they're a lab. They've done ongoing research for years. And they said, look, what happens if we get blood from people from 2015, 2018, before COVID-19 ever existed, right? 50% of those people had T cell response. You say, how's that possible? How could people have immunity to COVID-19 before it ever existed? The reason is because the coronaviruses have been around for many years. The vast majority of them cause no trouble, or if they do, they cause very simple colds. It was the rare COVID-19 or the original SARS-CoV-1 or the MERS, which were different, and they cause more severe infection, right? So it's to tell you that, yes, you could lose antibodies. Yes, you could see somebody had a mild infection, never showed antibodies. But if you studied people very carefully, they do have an immune response. They will be protected to some degree, right? Which is important for everybody to know about their ability to get a reinfection, their ability to transmit again. Those are the things that has implications for. So here's another way to look at it. Some people look, get this better with graphs. So I'm just trying to show you again, right? So you get exposed to the SARS-CoV-2 exposure, right? And then you start having the onset of some virus, right? So this is before symptoms, right? Here's before symptoms, after symptoms. Here's before symptoms, you start having some virus showing up, right? And you could actually isolate it if you knew that somebody's going to get it, you could actually find it, right? But then they get symptoms. Then they have their peaks, right? Within usually a few days, and then it starts dropping off. But look what starts happening, right? You start seeing that you can start getting those antibodies coming up, and those come up afterwards, and then eventually the PCR goes negative, right? You can't find in the nose anymore, but you do have the antibodies lasting there, right? Protecting you, right? Here's another way. In general, the immunity is going to happen by 7 to 10 days, which is why we keep saying those studies about, well, if you have somebody after about 6 days, 7 days, it's somewhere around there, they're no longer transmitting virus because you're getting that immunity. You're getting that impact. So you're killing off the viruses, right? So you're going to have situations where you could still test somebody and get some virus, but not necessarily infectious. It's not necessarily transmissible, right? And that requires some degree of understanding of how those properties work. Okay, rest up. And I want to talk a little bit about mass, travel, school, and then I promise, if you have questions, put them in the chat. And I will try to get to all the chat box after I'm done with all this so everybody can ask their questions and try to get to everybody. So if you want to put anything in any questions in there, put it in the chat box, and I promise I'll try to get to this right afterwards. Okay, here we go. Mask. If you have a simple face covering, you're trying to say, I'm trying not to give it to anybody. If you're wearing a high quality mask, you're trying not to get an infection, right? And the mask can be broken down in different ways about how good they are at doing these things. Now look, in general, the surgical masks are better. The 95 masks are the best, obviously, and then it goes up from there. It turns out that all the common masks that go around your ears, probably not quite as good as the ones that are actually with ties, and that's because you can actually form it to your face better and get it tighter around your face. So that's just to be honest. If somebody says to me, Mark, what's the best commercially available mask? I like the ones Argamot Synovia masks from Israel because they embedded copper. If you remember, when I showed you the surfaces stuff, it showed that it doesn't do very well in copper. It kills off very quickly. So keep that in mind. If you're trying to get one, they're not cheap, more expensive. But if you wanted a high quality mask, that's a good one for you, right? If you have mask wearing, there's going to be more asymptomatic disease. There's something about wearing masks. The people who wear the masks, if they get the infection, tend to be more simple infections. You will decrease your chance of getting an infection, even though primarily for simple masks, it's to prevent other people from getting it. A surgical mask can decrease the viral load to the wearer up to 83%. Right, so you can get that benefit, and the viral load going out can decrease 70%. Cloth masks can decrease the viral loads to the wearer up to 75%. So even though we always say classically, you say, if you're wearing a regular mask or a cloth mask or some kind of cotton material, right, then you're saying, okay, I'm trying not to give it to somebody, I'm not sure I'm giving a big protection, but you do get it both ways, right? Also, face shields. Face shields can protect the eyes. And by the way, there was one study in China where they showed that people who wore glasses were less likely to get infected, meaning that the normal route of entry is through the nose, but it could go through the eyes, right? So if you protect the eyes, that can also help a little bit in trying to protect somebody. Again, if you're outside, if you're socially distant, far away from people, 6, 10 feet, you don't really need a mask. You don't really need a shield. It makes no difference, right? But if you start getting closer to people, right, or you're not outside, that's a difference. That comes in, right? So we look at filtration efficacy of masks. You can see how it breaks down over time, right? So the top one is the fitted N95, the surgical mask, and then you can see slowly start to drop off a little bit into different types of masks, right? And of course, you get out to no mask, and then there was something that was very unusual in this study. People who were wearing fleeces, for some reason they were having equal chance to no mask. It seems like the fleece was a false sense of security somehow because the weave was so loose on some of these people that they were testing, okay? Here's an important slide. Please stay with me. That's really, really important. Watch this, watch. We in medicine will break down the hazards, right? So this is kind of the thought process that I go through when people ask me these questions, right? Where I say, no, you don't really need a mask. They go, oh, you're being cavalier or something. No, the science doesn't say that. The science says, look, if you're walking outside alone or far distant people, you don't need a mask. There's just no data for it, right? If you're in an urban area, okay, if you want to wear a mask, okay, you can wear a mask, right? If you're going to a retail store, okay, now you're saying, okay, I'm in a retail store. Maybe it's a big store and it's high ceilings and people are far away from each other. Okay, that's a little bit more of a risk. Maybe it's okay to have a mask, but all of a sudden you start telling me you're going on the subway, or you start getting into my world, the medical world, right? Now it's a different story. Now you're going to have to start protecting yourself more, right? That's where you start getting these high-level recommendations of doing these other kind of masks, right? So keep that in mind. That's why you have to be honest with this stuff. If you're going to go flying on a plane, okay, it's a different story. The airlines right now are saying, look, everybody, just keep your mask on, right? And so that's totally reasonable, right? You're in a more enclosed setting. By the way, the ventilation's excellent. So, quite frankly, your risk is still pretty low. And the surfaces are all wiped down, so your risk is very low. But having said all that, if you're on a plane and you want to eat and something, it's fine, right? But certainly, you can understand that when you're getting up or passing people or something, okay, then there's a little bit more of a risk, right? So when you're thinking about that, when you're thinking about what's necessary, what's not necessary, but look here, in most of these scenarios, these types of masks are not needed, right? And all these kind of things, the N95s and stuff, it's just not necessary, right? It's a bit of an overkill in that regard, right? Okay, here's another way to look at it. Again, a busy slide, so stay with me, just stay with me, but again, I'm trying to give you the same ideas here. We talk about occupancy. Are there a lot of people around you or little people around you, right? Are you outdoors? Are you indoors? Or is there poor ventilation, right? And what's going on there? Is there just silence? You're just walking along? Is there speaking, right? Or is there like shouting, singing, right? So you can see over time, depending on those scenarios, it tells you what you need to do, right? So if you're in this kind of environment, right, then it's very low risk of transmission. And if you do nothing or you do a little something, it's fine, right? When you're getting to situations where there's a lot of people, you're indoors, and maybe it's not well ventilated, and then you're going to be watching a choir or something, okay, then it's a different story, right? But if people are speaking, okay, it's medium risk or something like that, but otherwise it's not going to be a major problem for a lot of scenarios. But that's what you have to think about. Where am I going? Where am I traveling to? What environments am I going to be in, right? Because we have something called hierarchy of controls, right? Where we look at different ways of this kind of scenario, right? All right, now, real quickly, because I know people want to know about this, and then we're almost there, almost you survived this and stuff, but I just want to talk briefly about vaccines, because everybody's talking about this stuff. And so, look, there's a lot of stuff going on. It's very busy. There is a lot of research going on, over 170 products right now. Some have been held up, some are going forward. Some countries have started immunizing, again, on pretty weak data. It does show that the vaccines and some of these studies are doing what vaccines normally do. Look, I love vaccines. I'm always immunizing. I believe in them, right? But there is some data you have to know about. About 93% of all vaccines never make it to market. Most vaccines take $500 million to $1.5 billion to test, and it usually takes 5 to 10 years. So you can imagine that if you're making all these vaccines in a short period of time, are you going to know about the safety? Hard to know, right? We're getting pummeled in the medical literature about we're going to do it, we're going to do it, we're going to do it safely, we're going to watch it, we're going to look for safety signals. Everybody's working overtime. I have to say this is one of the areas that I thought was very well done by the White House and the Coronavirus Task Force, the Operation Warp Speed. Never been done before, really good, really unique, but you don't get something for nothing, right? Where they poured resources into this like never before, and that's why you're getting these accelerated programs of getting vaccines towards the market, and it's going to happen, right? But the question is, how do we know how reliable it is, how safe it is? That's something I'm going to have to be watching. So you could imagine that if one of you said to me, look, I'm 20 years old, 30 years old, should I get this? There's going to be a different answer than somebody who's 70 or 80 years old that has some medical problems that I need to consider protecting more, right? So those are going to be some of the considerations. Here's a busy slide just to give you an idea of the different mechanisms by which these vaccines act. So you can see there's all different ways that they work, going into the genetic code, going through viral vectors, going through a virus base and using proteins and stuff, all different ways. They teach you the flavor of how complicated this is, how involved it is. Final chapter is not in there. Air travel, okay? Overall, the airports are probably the safest they've ever been. They use 50% recycled air and HEPA filters. CDC suggests 14 days exposure in a high-risk area. But again, we don't view these as high-risk areas. As of the beginning of this month, probably 40 cases they think may have been due to air travel out of thousands and thousands of people traveling, maybe 40 cases. So it gives you a feeling of how little or how low likelihood this is. And by the way, this is very hard research to carry out. So they're looking to try to pin it on the airlines. They're looking for cases to try to show what's the worst case scenario. And at best, they're getting 40 cases out of thousands and thousands. It's very hard to know, were they really exposed? And when was it? Was it in the taxi? Was it in the transport bus? Was it in the airport? Was it in the TSA line? Was it actually on the airplane, right? Very hard to know. By the way, flip side, I've had many people ask me, they said, well, I'm just going to rent a car and drive across the country, have my kids come visit me. Well, look, if you're driving across the country, you can imagine that you're going to have to stop in gas stations and hotels and restaurants. And so that's going to be a lot more exposures than getting on an airplane. So in general, I think the airplanes are a better way to go. Okay, last one, schools. Because this overlaps with the travel, the kids in school. So that's something you're going to have to watch and keep in track of, especially for folks that are talking about seeing grandchildren or grandchildren seeing the grandparents. You know, this is a reality. Those kids, if they're going to school, are regularly involved in seeing a lot of people all at once. And if they're regularly seeing a lot of people all at once, then they have a higher risk of being exposed as kids. And kids tend to show this less than adults. So there is a little bit of a risk there. That's something that you have to weigh, right? But why in the world do all of us in general want to open schools? Because every study shows that distance learning is inferior. Virtual schools do worse than in-person schools. Schools allow for parental economic activity, which benefits all society and all health indicators. Closures of a school lead to lifetime loss of income for these students. It's unbelievable that some of their data. And kids benefit from the social development. And when you have school closure, it doesn't seem to correlate with control of disease very much. Now you're going to say, well, how's that possible? I'll tell you how that's possible. Because first of all, because the schools are a more controlled environment, kids are in those controlled environments. When you don't have school, some of these kids are going out for the day. They're meeting with their friends in parks. They're doing other things. They're not just sitting home isolating. Some kids are, but not all, right? So there's not necessarily control of disease, right? Next. We are not discussing colleges. There is some data about that in colleges. And they said that if you're going to go to college, you should test somebody every 3 days. So if you're somebody traveling to college, the optimal would test somebody every 3 days. Almost nobody does it, but that would be the kind of number you'd have to think about, right? That's certainly for the sports teams. We're testing the athletes every day to try to get control over this, okay? Who says to open the schools? Everybody. Virtually anybody you talk to, virtually everybody you talk to says this. And also there's been the whole thing about this document, the Great Barrington document by some very bright people talking about the importance of opening schools, opening the economy, not shutting down. I do support that based on the medicine and the science because of these kinds of things, okay? What are the risks to kids come back to school, okay? So it's low risk, right? And please keep in mind, the maximum fatality rate for kids is maybe 0.02%. It's probably even less than that, right? And so keep in mind that the vast majority of kids do well. And if they don't go to school, they start getting into drugs and violence and suicide and depression, which is a big problem for these kids, right? What are the risks to kids come back to school? They are rarely the primary source of infection in the home. And so we're waiting for more information on that, because there were some data that said, well, okay, if the kids go to school, they're with a lot of kids, can't they all circulate and then bring it to the home? It seems to be less common, but still possible, right? So that is something that you have to consider, right? The risk rises once you're talking about high school students, but still very low. About 1.7% of all kids under 18 have got the infection. But let me give you an example. In LA County, about 14,000 kids have had the infection. There's been about 1,000 hospitalizations. There's been no deaths, right? I'm not saying it's nothing. I'm not saying it's a real infection. I'm not saying to ignore the infection. I'm not saying that. I'm just trying to give perspective on when you're doing your decisions about who to visit, when to visit, what's the risk, right? For the kids, they are at very low risk of any serious problem, right? Can they possibly bring it to the home? Yes, the vast majority, though, have not shown that, right? What are the risks of kids not coming back? We talked about this, right? And what are the risks to teachers? So we came up with a document where we talked about for the teachers about whether or not they need to wear masks and what type of masks, and that depends very much on how common it was in the community, right? So you can always check the local information. So for example, in Los Angeles County, we have a page you can go to on the internet where it has weekly updates, right? And you can look at that. So if you're planning on traveling to a different area, you can find out what's the incidence rate of the kids or the schools, and then they can give you a guide about what might or might not be necessary, okay? And where's this been tried? This has been tried in a lot of places, right? And there's been few problems, right? There is France, for example, they tracked a COVID-19 positive kid in school, and not one of the 112 close contacts got the disease. Now, there's been multiple studies on this kind of stuff. There's one about a hair salon, where they had people with the whole aerosolization of the blow dryers and the dryers and everything flying around, and despite all that, a COVID-19 case did not get transmitted to 39 close contacts, right? So anything is possible, but you have to understand it's extremely rare for these things to happen, especially when everybody's doing different things, and it's been tried in many countries. Will you hear of upticks? Yes, but when they start talking about these upticks, you have to be very careful. Look at the absolute numbers. Look at the population at risk. What percent are we talking about here, right? And when they say, oh, it's 3% instead of 5%, look, anything is possible. But sometimes you're testing people more than once, so they always are showing up as a positive test, right? And you're testing people that are isolated, which means they're not going to transmit it. Those numbers are not placed into context, which can make it seem a lot worse than it is, okay? Okay. Remember, if you're less than 70, your fatality rate is 0.04%. By the way, the fatality rate from coronavirus is less than influenza, the flu. We give the flu shot every year, but I just want you to hear it once and for all. If somebody gets the actual flu, they are more likely to die from the actual flu than they are from coronavirus, right? No question about it. 65% of people are back to normal in 7 days. 81% if you were previously healthy. The counts are misleading because sometimes what they'll do is they won't put it in context. Any new test is a new case. They'll take it and combine pneumonia, influenza, corona, put them all into one category. The risk of being in a hospital is 0.068%. The risk of dying if you're over 65, 0.15%. That's the same as the flu, right? But you take the population as a whole, then it's less than flu, right? International fatality rate is 0.5%, right? That's less than flu, right? But this also includes poor countries, nursing homes. And if you do not go to school, go to work, you're going to get into trouble, okay? So quick summary, then I'll go to the chat box, right? See the doctor, diet, exercise, weight loss, where we talked about getting inside, very important. Get the flu shot every fall, that's important, right? Who should get the vaccine? That's going to be a good question. We talked about the mask, the face shields, range of option. We also talked about prayer being very important, and so that's always going to be very important. And that's it. Okay, so what I'm going to do is I'm now going to go to the